So I'm going to hand you over. Thanks very much.
Hi, thank you very much. It's great to be here. I think it's really exciting. It's a very vibrant event, and already I've been energised, and I'm sure you have. What I'm going to talk to you about today for this half hour, and do feel free to jump in at any time with any comments you've got or any questions. I'm very happy to be challenged as I go through, or if you just want to carry on talking to me, that's great. I'm going to talk about reasonable adjustments and really why bother, and what's the point of what we're trying to do. We're going to talk a bit about that, but what I wanted to do first was, because I'm not an expert, the experts in this room are those parents like Helen and people with a learning disability themselves. And what I want to do is read what a mother wrote to me in October last year. And it's a really important piece. It's from Yvonne Newbold. She's the author of Special Parent Handbook. She has 2 children with severe learning disabilities, and she has stage 4 terminal cancer herself. She is a lone parent. Those bits of information, by the way, it's not breach of confidentiality. She talks quite frequently with me, and she certainly raises those issues herself and talks it through in her book. So I will just read that forward before we go forward any further. What I would wish for. Hospitals will always be part of our family life. It goes with the territory when you have a child with complex needs. Even though I spend several hours, sometimes several days, and nights in hospital every month, I absolutely dread every minute we're there. It gets harder with each passing year. What one thing would make the whole experience more bearable? Well, that's easy. I wish that every single hospital employee could learn how to truly listen. Some health professionals barely listen at all. Others appear to listen. But you soon realise that it was only so they could formulate their reply. Occasionally, we meet someone very special who really listens, and with their whole selves, so they even hear what's left unsaid, linking in very much with what Valerie and her excellent work with Jean and Sheila over the years has been doing. They're the ones who make magic happen. As well as absorbing our words, they gain a tangible sense of what our lives are really like in a way that parents like me seldom experience. Time stops still while compassionate kindness soothes suffering. Whoa, that's powerful, isn't it? And in that moment, something profound happens. My sick child becomes the only thing that matters. You hear and take my concerns seriously, somehow knowing that this is my first adult conversation in days. You make me feel an equal rather than someone less. You understand all I say, even though I'm barely talking coherently. You help me make sense of all my fears. You acknowledge the essence of who my broken, hurting little boy is, barely noticing his disabilities and equipment. You make an holistic assessment based on quality of life rather than individual symptoms. When my child doesn't cooperate with your examination, you ask for and accept my help. I suggest we turn it into a game. You play along enthusiastically. You offer me a glimpse of the future when all doctors and nurses and healthcare professionals are like you, when we will all pull together on the same side, working in partnership solely to enhance my child's life. I can tell by your eyes that you know the things we haven't talked about. You recognise my exhaustion and notice how my hair hasn't seen a comb for a week. But you don't judge me or make me feel inadequate. You get how my life is. A never-ending merry-go-round of sleep deprivation, of coping with double incontinence, of tube feeds, of nasal cannulas, of oxygen saturation monitors, and an ever-present vomiting and chest physiotherapy in the middle of the night. You know how my son's fragility terrifies me, frightened that his tenuous grip on life could snap at any moment. You feel my guilt that I can't stop his pain. You sense how hard I work to help keep him alive. You know better than to ask me how I'm coping, because you know I'll always say I'm fine. You understand that that's better than me starting to cry and never being able to stop. So we don't go there. We don't have to, because for that moment, you were already there with us and for us. That's incredible, isn't it? And when you think about that mother, and then you think about death by indifference in 2007, so entitled because a father felt that his child, an adult at the time, it could have been a younger person, died at the hands of people very similar to us. Not nasty people, not malicious, but the indifference that took place. And that's what we really need to change. So reasonable adjustments. What are we actually talking about, and why should we bother? Well, these are some statistics. Baroness Hollins and others in the mid-90s found that you're 58 times more likely to die before the age of 50. Those of you in the room that know a man called Lloyd Page, who has a learning disability and works at MenCap, when he was 50, he was very, very excited, more excited than normal birthdays. And I said to him, why are you particularly excited? No, it's nice that you're 50. And he goes, do you know why, Jim? And I said, no. He says, because 58 other people like me didn't make it to 50. And that gave him a sense of pride and achievement. How sad is that? That was more exciting for him than actually turning 50 itself. Women with learning disabilities, we know, average will die 20 years younger than women without a learning disability, and men will die 13 years younger. We know that it's actually 3.5 people with learning disabilities die avoidably in NHS hospitals each day. That is not always, and very frequently, not the fault of the clinicians that are actually working with them. It's what's happening before they come into hospital. And Pauline and the Seapold and the others uncovered actually there's a lot of issues that are outside of the hospital. People aren't being picked up. People don't know that we've seen about the training already. That's very relevant and very pertinent. People don't pick up on signs and symptoms until they're too late. Or GPs and others, not like Neil, because I know he's probably a fantastic GP, had a lovely chat with him over coffee, are not picking up when people present at the same time as other people, aren't picking up the signs and symptoms, aren't believing people when they're saying they're in pain or expressing their pain through their non-verbal means. We also know that 8 million people in this country are functionally illiterate. Now, reasonable adjustments, we're talking about it for people with a learning disability, but we will only be successful. And in pushing it forward within your own services, the way to do it is to talk about the swathe of other people that it's going to hit and how it's going to impact. If you've got 8 million people that are functionally illiterate, you've got a huge amount of people whose words don't have the same meaning for others. But what we've got in the NHS at the moment is sadly an inertia that is highly tangible. And too many within the NHS are mainlining on 2 letters rather than 3. No is what you get very often when you express the need for change, evolution. That culture is damaging. Alongside diagnostic overshadowing, that is a killer. The culture of this is how we've always done it, therefore it's okay to carry on. That's killing people. It's killing staff from their motivation, but far more importantly, patients are not getting good care as a result. And it isn't just people with a learning disability that aren't getting good care. We know about older people, we know people with dementia, and many others. So change is hard because people overestimate the value of what they have and underestimate the value of what they may gain by giving them up. The issue as well is, if change is such a bad thing, why aren't we all naked and painting caves? We have evolved. Change is a constant. It happens. But change for the sake of change has no point. There has to be a reason and a rationale for your change. And we need to really think about the 5 values of adjustments on how we're changing and shaping services. Yes, it is a legal requirement, and use that as a stick for change. The nicey, softly approach to people. Yeah, be polite to people. I'm not suggesting otherwise. But people have to do things. It's not a sort of, this would be a nice thing to do. Please, could you? No, actually, you need to do this. It's someone's right. And as Jean said, the consultation is out today on people's rights, which is very, very good. It makes it very central to what we're talking about here. We need to value innovation. There's a bit about a cost going on at the moment about cuts. Look at how much money care costs for people with a learning disability. I've done some care and treatment reviews, and I inspect for the Care Quality Commission as well. some of the stuff I've seen has been beyond appalling and actually moved me very deeply, to a point where I actually had to write to those within those particular organisations to say, these are my concerns. These are the 12 things that I found really deeply upsetting. And these are 2 solutions. I'd welcome an opportunity to take them forward with you. We need to be thinking about solution-orientated outcomes, not about waffle and grandiose fluff. That gets you nowhere. That just kills people and stifles development. So we need to value innovation. We need to value the community, which we all are part of. We need to genuinely value partnerships, which obviously King's Partners does, and I very much would like to be a part of that. We need to be value for money, but we also need to value people. Value for money doesn't mean that you don't pay the right amount of money to get the right staff to do the right things. Those are actually cost savers in the long run, and they enhance people's lives. But people often don't look at that. Small actions by a lot of people lead to big change. The problem is, with the inertia that is rife at the moment within the NHS, up and down the country, that inertia is, I can't, I won't, and I'm not going to. That's the view. No. It needs to be, I can, I will, and I'm going to. And this is how I'm going to do it. If you look back into the 1970s, Persk wrote a seminal paper called The Dignity of Risk. Brilliant. But what's really happened about that? People are so risk averse that actually the no culture is, no, they can't do that. They can't do that. Why can't they? Give me a good reason. Okay, well, let's try this way. I went into service recently, and there's a young man there who loves Tottenham. That's his disability, unfortunately. And I said to him, I said, I'm really sorry for you. I can't help you with that. But I got his attention. Then I said, well, you know what? I don't know anything about football. I support West Ham. So he had a laugh back on me. And that was probably about the first time he'd actually laughed at or with a professional who's in a position of supposed authority or whatever. But it made a very different dialogue than what would have happened. But when I then went to the service and I said to them, has this guy been to see Spurs? And they said, no. I said, why? Well, the cost. I said, no, don't worry about the cost. He can get there. And they didn't really think about it. And then I spoke to one of the nurses there, and he said, well, do you know why, Jim? Actually, it's because it would freak him out. It's too big a crowd. He doesn't really like crowds. So what I'm doing is we're going to go to Brentford, then we're going to go to Orient, and then we're going to go to Spurs. So it's a gradual build-up so he can tolerate larger crowds. And I thought, great, there's a plan, rather than someone else who'd automatically, oh, no, it's just too costly. Actually, that really is, you couldn't be bothered. That's what that's about. So reasonable adjustments, why bother? Well, it's about being compassionate and what we should be doing. It seems very old-fashioned, but it is still very true. I serve people with a learning disability. I work for a particular organisation. I do not serve that organisation. Now, they may be uncomfortable to hear that, but that's the reality. You in this room are employed by whoever employs you. It might be Guy's and St Thomas's, it might be King's, it might be another. You're employed there. Yes, you have to work efficiently. Yes, you have to do all the things you have to do professionally and responsibly. But you serve the people. And we've lost that idea of service to people, to understand the reality. It is a legal compunction, a reasonable adjustment, and we do need to make them. It makes business sense. And I'm going to talk you through some of those, how that happens. Things like the hospital passport. This is John. John died a few years ago. But he was a wonderful character, and you can see he's far more handsome than me, and he's got a lovely smile. You'll see John's got one eye shut. No, he hasn't. He was blind in that eye because someone swapped a crowbar over him when he was younger. Why? Because he was different, because he's got a learning disability. So hate crime isn't something, or mate crime, isn't something that's just happened to these people. Isn't just something new, and Valerie in her work and many others know that these traumas happen all the time to people. Another person I used to work with and knew very well, Peter Cranham, and those of you who've seen Peter's story on the film will know that. Peter died last year, got very good care. After I left George's, I became his health advocate, and he got very good care in the hospital he was in. But a number of years ago, Peter had a glass shoved in his face, because he's got a learning disability. And that's just appalling. But things like the passport are really vital. They save lives. It's as simple as that. They save lives. If you read them and act on the information, you get things right. If you don't, you won't. It's quite simple. So when you go into hospital, this is what it feels like for an awful lot of people. And believe me, when I go to hospital, I'm definitely having a hospital passport, without a doubt. Because how can you expect someone who doesn't know you to know about your likes and dislikes, about how you express things and experience things that quickly? It's a way of helping our colleague rather than criticising them. The verbal lettering that you're getting here is a splattering of letters. That's just basically like a shower. And that's how it feels for an awful lot of people with learning disabilities. These things on the other side can really help enhance somebody's care and make it better. But also think of the bigger picture. Think about people with dementia who now are losing their ability to read if they were able to read before, but their functional understanding. Pictures enhance that. Do we feel patronised when we drive down the motorway because someone hasn't bothered to write an essay for us? Yeah, I want to read that. Oh, we're all dead. Well, there you go. That's just it. I wanted to read that. You don't feel patronised by that, do you? Road signs are there. Yet you'll get people that say, oh, we're not going to have pictures because that's patronising to people. Well, if words don't have that much meaning for you, that's not very useful. How many of you read the wonderful Department of Health documents and other government things that are about this fat? Or read the easy read one? Well, I know which I read. Of course, I read the fat ones. But you know what you want from that, and you can then take it away further. So what are we talking about in terms of actual adjustments? Well, the alert. You will get the political correct lobby that are just basically bigots in disguise with a veneer of niceness about them that will say to you, an alert, oh no, that's another label for someone. Well, someone who's in a waiting room who's now throwing tables around and chairs because they can't tolerate waiting. Well, you wonder, oh, they've got a learning disability. Yeah, but if you knew about that before they came in, you could have given them what we're doing is, you know, like Jamie Oliver's got those bleeps. So you get a pager that tells you when your food's ready. Well, if you're coming to a clinic at Great Ormond Street, you'll have 10 minutes radius that you can walk around, and if you go outside that zone, it gives you a little beep so you know to go back into the zone, and then it will give you a different beep to say, by the way, the next person's gone in, so you're likely to be coming in the next 10 minutes or whatever. Small changes, big differences. The alerts, put them on, they save lives. They also enable you to make business case. I can drill down and say, right, I know that since April 2014, I went to Great Ormond Street in September of 13. Since April 2014, I know that 1,640 episodes of outpatients have involved people with a learning disability that we've already got on the alert system. I know that roughly 12 people a week that are on the alert system are occupying hospital beds at the time. What I'm also trying to then do is use that data to look at non-attendance rates. So if someone's not attending, and we know people with a learning disability tend not to attend as frequently as others for various reasons, so if I know that there's 4% in the general population not attending and 8% of people with a learning disability, you see where I'm going with this? Target that, you enhance the care. You then have your arguments about what takes place. I'm the only consultant nurse in learning disabilities employed directly within a hospital anywhere in the world. And I created this post, and I created my last post. My point about that is, that tells you an awful lot about the value. We have a piecemeal effect within the NHS at the moment of a tick box exercise of saying, oh yeah, we'll get this learning disability nurse in here because, as Jean's rightly said, these are the things that we're being cross-mapped against by CQC and Monitor and others. Very, very important. This is a wonderful time, by the way, and I do like the CQC's Chloe's. I was a big critic of the CQC's previous one of inspection because I said, yeah, you can pass all of that. Doesn't mean you're any good. It just means you've met the standards. But this drills in. Is your service safe? Is it caring? Is it effective? Is it responsive? Is it well led? Brilliant. You've got to demonstrate those things. That's fantastic. That drills down a lot more to the core of what's going on than otherwise. What we've got at the moment is up and down the country band 6s and 7s going into hospitals to try to rectify the poor care. But they can't make big decisions. They're not very well supported. It's a piecemeal parachute approach of, oh, we've got this, let's chuck them in there. Let's see how they do. Well, some will swim, some will struggle, many will drown. Some will be brilliant. But that's not their fault that things aren't going very well. The system and structure, as we know, is not supportive of them. Training isn't recognised as a need, really, in many service areas, as we've seen already. But we know that as a national picture. Double appointments makes perfect sense. Environmental changes. These are the things that I am very, very passionate about now, and this is where I really believe that reasonable adjustments can change and alter practice very, very, very quickly. If you put in dimmer switches, as we've done in the pre-assessment area, which has been new build, in each of the rooms, this enhances, because the backgrounds are often very white, aren't they, in clinic rooms, but if you've got people with sight problems, they don't have to have a learning disability, again, thinking about other populations that struggle to use service and access, if they need the lights higher, they can have them. If they need them dimmer, they can have them. So if you've got someone who finds all the kit and caboodle a bit of a freak out for them, then you can dim the switch so they don't see all the kit and caboodle that's not necessary for their examination, if that's the case. It means that people are attending clinics appropriately, effectively, and we're getting things done. Clinics at the weekend, looking into that. Of course, you can start the debate about should it be in the evenings, can it be the weekends? Can you have learning disability-specific clinics? That's important to consider. Health checks, we know that that's not being done properly. What are we also thinking about reasonable adjustments for? What are community learning disability nurses doing? They're part of the equation here. They're part of the solution, as are the community team. But too many of them are in roles that they shouldn't be doing, such as care management, when actually it's very simple. Community learning disability nurses at their core and purpose should be doing health prevention, health promotion, health education, making sure that people have annual health checks, making sure that hospital passports are complete and up to date, and providing education within those settings where people have a learning disability, and making sure that if they are going to go into hospital, they have better outcomes, and they support the staff to pick up on signs and symptoms of poor health. Now, that is happening in many places, but it is not happening nationally. That's the issue. We need flexible visiting times. No hospital, so if you're working at Guy's and St Thomas's, I'm sure you already have this, but if you don't, cut out the fixed visiting times for people with learning disabilities straight away. That's a reasonable adjustment. It makes a massive, massive difference. You want the person that knows them best to be their emotional and supportive advocate to be there. You need them and you need their help because you will not be able to get it right on your own. Minimise waiting. I've given you a solution to some of those already. Increase the support for the person, for those that know them. Many of you will recognise this as coming from Books Beyond Words. Brilliant books, absolutely fantastic. And obviously, Valerie and I know Jean has used them in their clinics, and I use them as well. Really powerful because it helps you when you're thinking about the tricky things that Jean talked about, things about mental capacity, working out whether someone has capacity to make a decision or not. If you ask them to look through the pictures and the books about what's going on, they can then tell you what their interpretation of that is. Now, that may not be in a spoken way. It may be in an emotional, physical, non-verbal way that you can pick up on. So you then can start working out what's actually going on. Then, as part of your Mental Capacity Act assessment on their capacity, it's actually really brilliant because you've really detailed it. So when we think about the 8 million people who are functionally literate, how many operations are taking place in the country at the moment that are actually illegal? Where somebody has signed their mark on a piece of paper that they cannot read, and that surgeon has just broken the law and has caused an assault on that person. That's what's taken place, because if someone has signed something and they can't read it, and you have no evidence to say that you've used other tools, such as pictures, signs, symbols, photos, or descriptors of what somebody said. I get people to sign consent forms who can't read. Yes, I do. But what I then put is a note at the bottom, say, please see the medical notes, where I've detailed what else I've used to come to that conclusion with them in the assessment process. And often that'll be 2 or 3 pages in there, very detailed, descripting non-verbal, verbal language, what's going on as well. We have to change, and these are the people that can do it. We have to stop just talking about things like inclusion. I don't really get what inclusion is, actually, because I very rarely present at any talks without someone with a learning disability, or using per a parent's words, or directly quoting, as I have done, Peter and John, and mentioned Lloyd. That's just how it should be. We shouldn't have to have this separate thing of, we've got to include this person, we've got to include. It should just be the way it is. And that isn't the way it is in the bigger, wider world of services. And if we don't engage people with learning disabilities in the families themselves, in service design, accreditation, delivery, evaluation, and evolution, and the staff training, all of which, in my practice, I do. And next week, plug for a conference that I'm running, our 11th of March at Great Ormond Street. It is about a 50-50 split between the amount of people with learning disabilities and those without. But in the presentations, it's being chaired by someone with a learning disability as well as someone without. But the whole day is filtered through like that. And we've got 85 people coming. So it's a lot of different people. And we've got our friends from Baked Bean Theatre Company coming along. And I always smile when I see them. So they're fantastic. They've done wonderful work around health training and education at St George's and elsewhere. But we need to change the culture and shape the practice, and that's the way we will do it. So what are the quality what are we going to do? Innovation is the key. We need innovation in order to enhance the quality that we're providing, to be productive and to have strategies. What we really need to see in the NHS is a sort of a wonderful think tank that you get in business, where people are paid to just think up ideas and be creative and explore, because some of those ideas will be massive gems. This isn't a cost waste, it's a cost gain. They're an income generator when you have people like this. I would also urge you, if you're wanting to change and shape practice, get yourself sequins. I put in transition sequin for learning disabilities, part of the bigger picture, and that's going to draw down at the end of this month about £100,000 to the trust. And there's other cost savers, like we've got theatre protocol and recovery protocol we set up at Great Ormond Street. We piloted it. It's free. Anybody can take it. You can have it tomorrow at Guy's, St Thomas's, King's, wherever you want it. You can have all of the stuff that we've created. You can have the lot. Just take off the GOSH logo, put your own in there. We have the way the service is underpinned, the principles that underpin it. We have the theatre protocol. Again, you can use that. It's evidence-based. We know it works. So we have the solutions. But what we don't have are necessarily the levers nationally to really impact on that. But that is changing. We are in a good time. We just need to make ourselves really lean, clear, and efficient in our insightful ways. We need to have responsive care outcomes. These need to be care within hospitals and health settings generally that are specific to the individual. Now, people will think that's very costly. Not really, because you can have core reasonable adjustments and then you can have bespoke ones. The cost is when people don't turn up and when people die and poor care happens. That's the cost, both in people's lives but also in society in general and financially. Reasonable adjustments created flexibly to respond to the need as they arise to enhance outcomes. Care outcomes to be measured against how responsive they are to individual changing needs and to form core parts of contracts, as well as the expectations of those who use the service. So we're talking a bit about rights today, and that's coming through. This is linking into that. And it's about what you should expect from your service. If I go to Tesco's, I don't expect someone to ignore me. I expect them to like me, and other leading supermarkets, by the way, just so that you don't think I'm a Tesco's head. Key part of quality of service provision needs to be about admission and funding agreements before people coming in. We should be looking to get people out rather than to keep people in. We do that in acute hospitals rather well. Sometimes a bit too well, people going out before they should. But within the learning disability arena, where people are in low, medium and secure and other institutions like that, they seem to just be able to stay forever and a day, where actually many of the things aren't happening that should be happening for them. So the value of the person is core. We need to recognise individual worth, and we need to seek achievable, measurable outcomes from the first point of contact, incorporated in a flexible, active, outcomes-orientated plan. where there is a measurable change. You've heard from Valerie about measures. You've seen, obviously, the work that she did with Sheila about the fact that actually these things can work really for many, many people, a whole range of people. We can identify how we're improving people's lives, but we need to get that right. So reasonable adjustments are the cornerstone of effective, efficient, well-led, safe, caring and responsive services. If we're not doing that, then we fail people. We fail our fellow human. They are the only way to get care right. And without them, more people will die unnecessarily every day. Thank you.